Yes.
Can you see it? Good.
Yes.
Okay, so thank you to Sarah and Rupert for inviting me today. My name is Christine. I'm an associate professor at Columbia, and I'm going to be talking about a paper we recently published on the sex-specific effects of ketamine and some of its metabolites. So typically with stress and depression, stress is the impetus or precedes the onset of depression or PTSD, and then patients are usually treated with symptom suppressing drugs and whatnot. But something that interests my lab and a number of other labs is, why does this not happen to everybody? Why are some resilient and do not develop depression or PTSD from a stressful life event? And this picture, I think, is just a great representation of that, in that some people have this resilience built into them and do not become susceptible, and whereas others become extremely susceptible. But there are also things that you could do to increase resilience or increase your resilience against the stress. So something that we did not plan on studying, I will be completely honest in saying this, these effects were basically found from doing a completely different set of experiments in which we were using ketamine as an anesthetic. But what we had found out is that you could give a single injection of ketamine and then stress the animal at a later time point, and those animals were essentially protected against the stressful life experience. And so the model that we have now built over the last, almost 10 years is to develop small molecule prophylactic compounds that could essentially provide long-lasting protection against stress-induced psychiatric illness. And initially, all of the papers that we had published were to give an injection way before stress. But with the newer stuff that we have been developing, we believe that you could actually give a drug immediately after stress, not wait for the person to develop stress-induced depression or PTSD, but give an injection that's prophylactic to the development of a stress-induced psychiatric disorder. And I would like to preface this whole talk with saying that we are not advocating for everybody to get ketamine. We don't want everyone to get ketamine, but we think from a basic neuroscience perspective, using ketamine as a resilience-enhancing drug to figure out the mechanisms of resilience is extremely interesting. But using these or newer drugs to basically protect in a prophylactic manner, I don't think that prophylactic idea has been brought into psychiatry yet. In most other diseases, we try to prevent them before we develop, but in psychiatry, in many times we're just waiting for the patient to develop something and then begin treating it. And the work I hope to show you today is that maybe we can start thinking in a prophylactic mindset and try to prevent these disorders from developing rather than treat after. So in the first study that we had published a couple of years ago now, we used a model called social defeat. Social defeat is a routinely used model in labs as a chronic stressor for rodents. This is just a picture over here of the aggressor in white and another mouse. In this case, it's a black C57 animal. And in this paradigm, animals are co-housed for weeks, and every day the divider is lifted up and this animal attacks this animal. And when you're done allowing these fighting bouts, you put a divider for the cage that essentially allows the animal to smell and see the aggressor on a daily basis. Eric Nestler and a number of labs have basically used this model to show this is a robust stress model in animals, resulting in a long-lasting stress phenotype. And what we had done here is given a single injection of saline or ketamine 1 week before stress. In this case, it's a social defeat stress, which lasted for 2 weeks. And then we tested a number of behavioral phenotypes, such as behavioral despair, anxiety-like behavior, cognition, hyponeophasia, and looked at the effects of this injection of ketamine now weeks before the test. And if you look at this bar graph on the right, it's the easiest bar graph to show you what we found. In control animals that do not undergo this stressor, this injection of ketamine or saline does not impact a measure of behavioral despair or immobility time in the forced swim test. But the animals that were administered social defeat, they have an increase in immobility time or an increase in behavioral despair when compared to the control animals. Now, the animals that got this injection of ketamine 3 weeks now before the forced swim test, their levels were back down to control levels and had a decrease in immobility time or a decrease in behavioral despair. I'll summarize other stuff that we had done before I get into this paper today, but this basically showed that this single injection sub-anesthetic, in this case, in a rodent, it's 30 mg per kg, so it's not in the anesthetic range at all, produced long-lasting effects that essentially protect the animal from developing this behavioral despair phenotype. We also use another paradigm in the lab called contextual fear conditioning. This is a single trial stressor. Animals are placed in a box and receive one or a number of foot shocks. And when you place the animal back in the context, you can measure freezing as an index for memory of the fear that they had learned, or if they have exaggerated fear, meaning they freeze in an exceedingly large amount of time in the box compared to control animals. And so we wanted to know, does ketamine protect against fear behavior as well? And so animals were given, again, a single injection of saline or ketamine 1 week before fear conditioning. And then we used an extinction trial where they were basically put back in the context multiple times to look at how they can extinguish their fear from the aversive experience. And if you look at this, red box over here, you can see that the ketamine animals never mount the same fear response as the control animals, in that they had a blunting of fear, and the animals do not differ in their extinguishing profiles. And so these data showed us that not only can ketamine protect against this behavioral despair or depressive-like phenotype, but these animals can also be protected against exaggerated fear following a fear paradigm. The last background I will show you is on a paradigm that we routinely use now. This is a paradigm used in humans and in rodents. It's called pattern separation or contextual fear discrimination. And in this paradigm, animals are given a single brief weak shock in a context we call A. And then every day they are put in that context A and a very similar but neutral context B. And in this paradigm, a number of studies have shown that humans with PTSD, or actually aging humans, are impaired in pattern separation and that they can't discriminate between the two contexts. And a number of studies have shown that this assay is dependent on hippocampal function, specifically the dentate gyrus. And so what my postdoc Alessia, who was trying to call in before, had shown, if you look on day 6 of this paradigm, you can see that control animals receiving saline or animals that were given ketamine freeze equally in A, the aversive context. But the animals that are given saline have almost comparable levels to the A context in B, which is the neutral safe context. But the animals that were given prophylactic ketamine, now days before, or weeks before at this point, had much lower levels in context B, and they did not generalize their fear from the aversive context A to context B. By day 10, both groups learned that B is non-aversive, and so they have lower levels of fear, and they freeze more in A, the aversive context, and less in B. What we did not publish in this paper, which is, I think, the biggest effect that we had found, is that that single injection of ketamine 1 week before this assay, we saw protection for 6 weeks after, and the control animals went back to generalizing their fear, whereas the animals given this ketamine injection did not generalize their fear. So again, just for time's sake, I'm not going to tell you all that we had done, but I would like to give you some context to why we did the metabolite study. We found that ketamine decreases stress-induced behavioral despair, social avoidance, learned helplessness behavior, learned fear, and decreases fear overgeneralization and context fear discrimination. We used a number of models now to validate these effects, whether it be chronic or acute. So social defeat is a chronic assay. Learned helplessness is a single severe fear-based stressor. We've used a neuroendocrine model of stress called chronic corticosterone, And we used a contextual fear conditioning assay like I've shown you, and more recently done by Alessia, basically an LPS or an inflammation-induced assay. We have found that ketamine is ineffective in preservative behavior. It does not alter fear extinction. It does not change locomotion at the doses we're giving. And we do not see effects in hyponeophagia or eating in a novel environment. It's also dose specific. We have robust effects at 30 mg per kg in male mice. And in a different strain of animal that is a more resilient strain, we've pushed the dose up closer to the anesthetic range and can get effects at 90 and sometimes 10 mg per kg. But the 30 mg per kg is sub-anesthetic and the most effective a dose that we've found across the board. So when Rupert and Sarah asked me to come, they said that there are a bunch of clinicians in the audience. And so I would like to give some clinical relevance to what we're essentially doing here. We published this paper and all these reporters were asking us about this. And I started, trying to read more and more. And I came upon a paper that I did not know about when we published the prophylactic paper. And in this study, Iraqi war veterans that were burned on the battlefield were given ketamine or a different anesthetic to deal with the burns, essentially, that they received. And what the authors had found is that if they were given a different anesthetic, there was a 46% prevalence of PTSD, whereas the soldiers that were given ketamine, it was down to 26% of PTSD. So this was a huge reduction in the prevalence of PTSD. And again, this is not prophylactic to the burn, but it's immediately after the burn or the stressor, but prophylactic to the development of PTSD. And so this gave us some impetus, I think, to say this could be a viable option for protecting patients in a known stressful environment like soldiers or frontline workers, rather than waiting for them to develop the phenotype much longer after the stressor itself. Another really interesting study that came out after we had published a bunch of this now, in this study, women with a history of postpartum depression gave birth, and then they were given a bolus of ketamine immediately after the birth. And you can see that the ketamine group compared to the control group had a significant reduction in the prevalence of postpartum depression. There were a number of other phenotypes that the authors report, but again, it gives validity to our preclinical work that this could be potentially used in a clinical setting. So how did we get from ketamine now to the metabolites? And so while we were doing this paper came out in Nature now 4 years ago from Todd Gould's group, led by a man named Panosonos, who's great. And they had postulated that one of the metabolites of ketamine was driving the antidepressant effect. And what was interesting, it wasn't the S enantiomer like S-ketamine, it was the 2R6R-HNK that was basically mimicking or acting like the parent RS compound, in that the animals given 2R6R-HNK, but not 2S6S-HNK, had a reduction in immobility time or behavioral despair compared to control animals. They saw a similar phenotype using the learned helplessness model, in that the RS-ketamine, the parent compound, and this 2R6R-HNK, but not 2S6S-HNK, reduced this depressed phenotype. This paper also postulated that ketamine was acting via an NMDA independent mechanism, which we're not going to get into today, but we can discuss that later. And, this paper has caused a lot of discussion in the field from the basic perspective of what is driving ketamine's antidepressant effects that you see in the clinical population. So I'm guessing most of you know about S-ketamine from Janssen, and you have R-ketamine, the other enantiomer. Today, I'm only going to be focusing on the 2R6R-HNK or the 2S6S-HNK. And so the questions we had were, is ketamine prophylactic against female and male mice? Are any of the metabolites of ketamine prophylactic in female or male mice? If so, is there a common mechanism that may be mediating this action? And last but not least, do ovarian hormones influence prophylactic efficacy? And so the paradigm I'm going to show from the rest of the paper, it's basically the same thing. Animals get a single injection of saline or ketamine or a metabolite. 1 week later, they are then stressed using a fear conditioning assay, and then we measure behavioral despair or depressive-like behavior in these animals. And so in this study, we injected ketamine or the metabolite 2R6R-HNK or 2S6S-HNK into male 129 mice. And we found, oh, I'm so sorry. We found that the RS ketamine, I don't know what's going on today, I'm apologizing. We found that the parent compound decreased freezing to the context, so they did not mount the same fear response as I had shown you earlier. The 2R6R-HNK did not do anything to fear behavior, but the 2S6S-HNK across the board, except for one dose, dramatically reduced fear behavior in these animals. When we looked at behavioral despair, again, like I had shown you earlier, we see a decrease in immobility time in the forced swim with the parent RS ketamine, but only one dose of the 2R6R-HNK, an extremely low dose, 0.075, was effective in male mice, and none of the 2S6S-HNK doses reduced this depressive-like behavior in male mice. We next wanted to see, is there a mechanism or is there a common target from all of these metabolites in ketamine that could be mediating these effects? And for limit of time purpose, we had, from Alessia's earlier paper, picked out a part of the hippocampus that was mediating the effects of ketamine. And this region is called CA3. The dentate feeds information into CA3. And so we wanted to know, could there be some signature in this area that may be mediating these effects? And if you look at the blue circles that I have on the screen here, these are large AMPA bursts. And in control animals, we have these large AMPA bursts. But animals that got a prophylactic ketamine injection 1 week earlier, there are no large AMPA bursts in CA3 if they were given prophylactic ketamine. And if you look at 2R6R-HNK, the drug that reduces behavioral despair behavior or depressive-like behavior in male mice, the AMPA bursts are gone, just like the parent compound. But if you look at 2S6S-HNK, which did not alter behavioral despair behavior, those AMPA bursts are still there. And so now we have a phenotype, an electrophysiological phenotype in CA3 that's mimicking what we see with the parent compound and paralleling the behavioral changes. Obviously, in females are twice as likely to develop depression as men, but historically in rodent studies, people have used male mice, male rats for many, many years just because of the cost and the complexity of running female mice. And so in this study, we wanted to see, does the dose that we give the male, is it as effective in a female mouse, essentially? And so we did the same thing where we injected saline, ketamine, or the metabolite in female mice now. We waited a week, we stressed them with fear conditioning, and then we assayed a number of behaviors. And what we found is that ketamine at all doses tested does not affect fear behavior. 2R6R-HNK does not affect fear behavior. And one dose of 2S6S-HNK actually increased fear in the female mice. So if you remember from the males, the parent RS compound drastically decreases fear in the males, but here in females, nothing in the fear is changed at all. We then looked at the depressive-like or behavioral spare behavior, and we found a dose of ketamine that actually reduced immobility time in the forced swim test, and this was 10 mg per kg, so a third of what the males are getting at 30 mg per kg. If you look at the 2R6R-HNK, if you remember with the males, 0.075 was effective, and now here 0.025 mg per kg was effective in females, and none of the doses tested, like in the males, for 2S6S-HNK were effective in behavioral despair. So in both the 2R6R-HNK and the RS ketamine, the dose that is effective in females was a third of what we were seeing in the males. Just for time's sake, I'll quickly tell you that we validated all of these effects, again, using multiple stress assays in rodents for females. And here we used a learned helplessness assay. And we found, if you look in G on the bottom right, that ketamine, again, this is 10 mg per kg, and the 2R6R HNK, which is 0.025 mg per kg, drastically reduced immobility time. The line graphs are here in females compared to the control animals that were stressed. So it was not just for fear conditioning, but it also worked in this assay as well. We used a chronic stressor like social defeat, which is not super effective in female mice. We used chronic immobilization stress in the females. And just like the learned helplessness, we validated our effects with the ketamine and 2R6R HNK, that it again reduced behavioral despair in females compared to control animals. So the last part I want to end with, and I'm sorry I'm going a couple minutes over, we cared about what are the effects of the ovarian hormones on the effects of ketamine. And in our mind, we had thought if we get rid of the circulating, or we ovectomize the animals, we could shift the dose that was effective in females to the male dose. And that did not happen. But what we found is that if you overectomize the animals, you take out the ovaries so they don't have all of these circulating hormones, you completely block the effects of ketamine. And if you look at this bar graph on the right, the blue is the RS ketamine, and the 2R6R HNK is the metabolite. It works in sham animals, but once you OVX the animals, you lose the effects in female mice. And so we started to add back in the either estrogen or progesterone and said, what do you need to get the effects of ketamine to come back on board and be effective in these animals? And what we found is that if animals were given estrogen in basically a pump to give it chronically, you could start to get the effects back of the metabolite of ketamine, the 2R6R HNK. But only when you have estrogen and cyclic progesterone do you restore the effects of ketamine in the female animals back to what you saw in intact animals that did not have an overectomy. So to summarize the paper and kind of briefly what we've been working on, we found that a single injection of ketamine can have long-lasting effects in animals against maladaptive behaviors in male and female animals. The 2S6S HNK attenuates fear, whereas the 2R6R HNK prevents this behavioral despair or depressive-like behavior, if that's what you want to call it, in rodents. In female mice, the 2R6R HNK prevents the behavioral despair, but does not alter fear behavior. Neither does the RS ketamine, which you can see alters fear behavior in males. This prophylactic RS ketamine and the 2R6R HNK, they have a common electrophysiological signature in the hippocampus, specifically in CA3. We don't see this signature with 2S6S HNK in that it removes these large amplibursts in CA3. Ovarian hormones may mediate the prophylactic efficacy of RS ketamine and its metabolite in female animals. And I think this is really important because in a lot of the cases I've seen, you don't see ketamine being super effective in the elderly or aged population. And so this is something I think we need to think about when administering these drugs to either, elderly females or whatnot, because it clearly does impact how these drugs are effective against a psychiatric phenotype that we can study in rodents. And lastly, what I think is super important is that in our hands, at least, and again, other labs have shown this as well, that the dose that we're giving the males is not the dose that is effective in the females. In the females, we see effectiveness at a dose that is a third of what we're giving the males, not only for the RS ketamine, but for its metabolite. And, I just want to end that from a neuroscience perspective, we have studied males because it's easy. It's cheaper, it's direct, but I don't think that's the way to go. And so from an NIMH standpoint, we're trying now to study sex differences, and it's important to study this, and it's very complex, but we can't treat females and males as the same, especially when we're looking at these complex phenotypes. And more importantly, this may differ from the clinical side, but in rodents, people would, test drugs and say, oh, we get an effect, it's great. But what this paper really showed is that treating fear or depressive-like behavior with ketamine and its metabolites is super complex, because if you're just looking at one assay, you would say the drug would not work. And so if you looked at fear and you were only looking at 2S6S HNK, that drug robustly reduces fear behavior in male animals. If you looked at depressive-like behavior, you would say these drugs don't work. Whereas if you look at depression, the 2R6R HNK affects this behavioral despair behavior in not only males and females. And so I think it's really important we start, building into the pipeline these complex assays that can separate all of these phenotypes that you would see in patients, because it shouldn't be a one drug fits all. Maybe if you have a patient with extreme fear, maybe the metabolite one day would be effective. Maybe a patient that has severe depression doesn't have a fear-based phenotype, maybe give it the metabolite 2R6R HNK. So it's just something I would like to put out there and, make people think about, because it does impact the efficacy of the drugs based on the tests that you are looking at. And so I'm sorry, Sarah, for going a few minutes over. That's it. I hope I didn't bore you all today. And thank you for listening and signing on Zoom during COVID. And I hope everyone's safe. And thank you for listening.
Thank you very much indeed. Christine, that's absolutely fantastic sort of tour de force there, and really clear. Sarah's going to kick off with the questioning.
Oh. Yes. So we already have some very good questions from our Q&A. For example, Antonio Metastasi was asking when you were presenting your work, so what would be the equivalent dosage in humans of the ketamine you use as a preventative treatment?
We get this question a lot, and I think we're definitely giving more than the 0.5 mg per kg that you would give an IV to a patient. I don't have the exact dose. We have not measured what is the concentration in the blood. We are doing that. But to give you a phenotype perspective, if we put a mouse under to do surgery, that dose is 100 mg per kg of ketamine. And the typical antidepressant dose that people have given to rodents is 3 to 30. So we're at the higher range of it, but it's nowhere near the 100 mg per kg that they get as an anesthetic dose. So I think it's definitely more than the antidepressant dose that we give, but not in that range at all. And most likely it's definitely way more than the 0.5 mg per kg that is given in an IV. But again, it's IV versus an IP injection, so that also factors into the equation.
And then we have another question from Tiago Gil. I hope I'm saying this right. So in how many, for example, percentage like animals does ketamine help? Was all of them close to maybe 75%?
So I am a stickler for now. We report every dot of every mouse in every study. The earlier stuff, it wasn't like that. We did the first experiment and we thought it was like a total fluke because no one was socially defeated. And the background of this story is that we were giving ketamine as an anesthetic to irradiate animals to look at neurogenesis. And we kept getting these behavioral effects 6 weeks after. And we honestly did not think it was true. My grad student did this, and then we did it again, and we did it again. And we literally were like, this is the most insane effect we've seen. In these studies, we see more than 90% of the animals being completely protected. In some cases, you don't see any susceptible animals. And so now, plotting every animal, you can see how protective it is. It's not 75%. It's way more than 75%. You would get an animal here or there that would not be protected, but it was not like a typical spread that you would see in a drug study. It was much more profound. And so that's a long answer to your question, but it's way more than 75%. So.
Very clear answer. We have also another question from Dr. Glenn Brooks. So based on your research, racemic ketamine is more likely to be clinically effective than S-ketamine alone?
So we have not tested S-ketamine, like we went straight to the metabolites. We should have tested S-ketamine. Maybe we will one day. We're just, I don't know. I'm kind of past S-ketamine. I think there's a lot to factor in, and I don't want to say that the parent compound is going to be more effective than S-ketamine. We're giving these IP injections. It's not an intranasal spray like we're doing in humans. So there's a lot of factors there that feed into it. But you have with S-ketamine, right? You don't have all these side effects of the parent R S-ketamine. However, in rodents, at least, we think the parent compound is effective at fear and depressive-like behavior. And when you split it up, you split up it being targeted towards fear or targeting towards depressive-like behavior. So at least in my hands, I think the parent compound is much more effective against both than when you separate it. But I don't want to make, you know, a broad jump to humans that are giving it differently than an IP injection in a mouse. So I still think S-ketamine is super helpful in humans, obviously, and it's being given, as you know, on top of antidepressants. So I'm just going to speak for the mouse psychiatry field, if that's okay.
And, you know, I have a further question on my end this time. You know, you were talking about the last part of your talk, found very interesting and very novel, about the role of like female hormones on the effect of ketamine for the animal models. And I was wondering, what about the role of like male hormones for the effect of ketamine?
We get that question all the time now. People are like, are you going to castrate the males next? Okay, maybe we'll get there at one point, but I think it's super important as well. I mean, we haven't done that yet. I mean, this is, you know, we're trying to break apart this phenotype that one administration of this drug could have effects for 6 weeks, one injection. And so there are all these things that come into play, especially in the females, because it's over such a large period of time. They're cycling many, many times in that 6 weeks or period, or a week at that point. And the same for males, like maybe the status in the cage, maybe their hormones are affecting it. I don't know yet, but we get that question all the time now. It will be next, it will get there, next grant.
And so, and related to that is like also like, for example, the hormones then are also necessary like to like the development of the depressive phenotype later on.
Exactly. I mean, we've done the study where we over-optimize them early on, but people have brought up the question of like, if you give the drugs and then over-optimize them, I mean, you could play with all of these different time courses. So we don't know. I mean, it's obviously very complex, but at least based on this more recent work that we've published now, it does influence the efficacy. And so it makes you have questions of like, what if someone's progesterone is off when you give the ketamine infusion or S-ketamine? Does that influence how effective it will be at a later time? I don't know. I mean, these are all important questions that we haven't really thought about when, you know, I think bringing a patient in, let's just give them ketamine to help them, but there may be other factors we need to check before we start doing that kind of study. So.
And I would assume this applies also for like before the development, right? At the puberal age of, I mean, not an animal person, but I assume.
Yes.
Could be translated somehow.